Hi guys.
Hi.
Hello.
Hi.
Good morning.
Hi. How is your Sunday going so far?
Good. Happy Raksha Bandhan.
Yes, happy Rakhi, happy Raksha Bandhan. You
Happy
guys
Raksha
had
Bandhan to all of you.
you guys had a good time today? Were you able to tie Rakhis and everything?
Yes, Akansha, how are you?
Good, Dr. Iqbal. How are you?
Good. Did you get some time to rest?
Yeah, of course.
Yeah,
Yeah. Mhm.
yeah. You just moved in.
Yeah. I mean, the unpacking will go on, but that's fine.
Oh, is it?
Okay.
Yeah. Then again, it will take some time.
Yeah.
Our sessions, I think, are going very good.
Yeah, I like those sessions. I like our sessions too. It's, I mean, everything is like a lot of learning.
Yeah, a lot of learning.
Yeah. Okay, ready to start?
Yeah.
Okay, let's start then. So, someone wants to take this flow? Prerna, you available here? Shweta is here as well.
Yeah. Can somebody start? I just like 3 days I was off and I'm not on track. So just give me,
don't worry about it.
I can try.
I need that vigor to start. So
Yeah, Nidhi, go
the
ahead.
first game, if somebody can take, second I'll take.
Yeah. It's just, it's not the case with Shweta this time. It's just the book right now.
Oh, so you,
So,
I
yeah.
missed yesterday's session. I don't know like how you did it. So just like give me, let me have an example
Don't
of how
worry.
others
You
are
take
doing
your
it.
time. Don't worry.
Yeah.
Take your time. Yeah. Okay, let me mute all. Nidhi, you unmute yourself. I think you were saying that you'll do this. Just a second. Huh?
Yeah,
I'm
sure.
muting all. Yeah, go ahead and unmute yourself.
Okay.
Yeah, go ahead.
All right. In the first plot, CD45 versus site scatter. First thing to note, this is peripheral blood. So, like just the normal population, green is granulocytes, pink is monocytes, blue are lymphocytes, and we have this little yellow above granulocytes, which may be EOs. I'm not sure what.
I think they're used to.
Yeah. Okay, and then we have this in the blast zone, we have this increased red population, which seems like definitely increased. Okay, let's see what these populations are. In the next one, these cells are CD34 positive and express like somewhat like I'll say dim CD38.
Right.
Then they are CD34 positive, and again, like a subset is expressing CD15 and a subset is not expressing CD15. Then they are CD34 positive and CD33 negative, I'll say. Then they are then again a subset is expressing bright 13. Then they are CD30 CD117 positive.
Right.
And low CD38. So basically, these are blasts. They're in the peripheral blood. They are increased blasts which are CD34 positive, 13 positive. Subset is 15 positive, and DIMS CD117 positive, and DIM CD38 positive. So basically, increased myeloid blasts in the peripheral blood. That's all I can say so far.
Right. So it's basically acute myeloid leukemia, and this over here is kind of like a garden variety acute myeloid leukemia rather than a specific type, like for example rather than 821 or 1517. This is just acute myeloid leukemia, a garden variety that they have given. So I will not go in much detail since today we are going to be going fast. So malaise, fatigue, past 3 months, there is WBC count of 76,000, and hematocrit is low, platelet is low, and then they exactly what you explained. That's what they are writing over here. So flow cytometry, expanded population of cells with 45 versus site scatter, defined by blast gate. Population is colored red and noted to express 34 and 117, and indicating immaturity. The CD34 blast comprise 67% in the WBCs. And the abnormal blast express 13. What happened here? Yeah, the abnormal blast express 13 over here in the subset and 117, low 33, and indicating myeloid lineage and aberrant expression of several markers, including bright subset 13 positive, low to absent 33, and bright 34, and CD38, which is low. All of this is noted. In the blast show no expression of B and T cell lineage markers, which were not shown. And findings in conjunction with morphologies of acute myeloid leukemia. So AML is myeloid stem cell neoplasm characterized by block in myeloid maturation with an increase in proliferation of immature elements, most commonly myeloid blasts. Several classification systems have been described, WHO. In current practice, the WHO is defining AML as more than 20% and divides AML into primary 4 categories. So RGA and MRC, therapy-related, and NOS. Of note, the diagnosis of AML can be made in less than 20% blasts if there are 3 of these. So 821, 1517, also 1717, and inversion 16. And although AML is present as a marrow or in peripheral blood disease, in some cases it may manifest as tissue-based myeloid sarcoma. So then they have all the RGAs. So 821s, inversion 16, translocation 1517, translocation 911, the MLL1, the DECNUP 69, inversion 3, the EV1 is inversion 3, and 122 is more of MKL, and MKL is more megakaryocytic. And the provisional entities NBM1, the biallelic mutation of SEPA. And then AML-MRC, therapy-related, not otherwise specified. So not otherwise specified will be all M0, M1, M2, M3, and so forth. So flow cytometry is well-established role in evaluating cases of suspected AML. Flow cytometry can assist in identifying and defining the lineage of the blast population, demonstrating that blast population is immunophenotypically abnormal or different from normal or regenerating myeloid blast population. And particularly in the peripheral blood, flow cytometry can be helpful in the blast enumeration. However, as noted in chapter 5, acute leukemia flow cytometry will be unreliable for the blast enumeration in the marrow, and morphology is therefore the gold standard. In addition, flow cytometry is used in subclassification and prognostication of AML. So, for example, CD56 we read is bad prognosis in case of 821. So this chapter will provide an overview of use of flow cytometry in AML with following cases, that is 26 to 31, providing specific examples of the AML. Blast equivalence would be abnormal promyelocytes in case of APL, and AML with PML-RARA, and then monoblast and also promonocytes, and in case of monocytic differentiation. All right, this is all introductions. So myeloid blasts are immature cells, and as such typically express 34-117. 34 is early stem cell marker. CD117 is expressed on the hematopoietic stem cells with increased expression committed to either erythroid or myeloid lineage, and expressed in 65 to 80% of the myeloid blasts. So erythroid lineage and myeloid lineage, we have 117. And of note, CD117 is expressed through promyelocyte stage and is also expressed on the proerythroblasts. So the expression of CD117 in isolation does not define a cell as blast or define its lineage. In addition to markers of immaturity, myeloid blasts should demonstrate the expression of myeloid antigens, which include 13, 33, 15, and MPO. MPO is lineage defining antigen, has typically present in some levels on the blast in AML M1 and M2, but is less commonly expressed on AML M0 by definition. Other markers useful in evaluating AML includes HLA-DR 4, 11B, 38, 64, and 123. As these markers are typically expressed at varying levels during normal myeloid development and may assist in defining myeloid progenitor as abnormal if they are aberrantly expressed. Expression of non-lineage specific antigens is a common immunophenotypic aberrancy encountered in AML, and therefore evaluation of lymphoid antigens. So 2, 5, 7, 19, 56 is recommended for the workup of AML. Although not common, TDT has been described in approximately 10% of the AML cases, most commonly reported in AML M0. The expression of TDT therefore should not be considered as evidence of against the myeloid lineage. So we know that for B lineage, the CD19 And for T lineage cytoplasmic CD3, those are the lineage defining. They are saying that TDT should not be considered as evidence against myeloid lineage. Aberrancies of blast immunophenotypes in AML are similar to that which may be seen in other myeloid stem cell neoplasm. So basically, MDS kind, MPN kind of aberrancies can be seen. So basically, abnormal increase in intensity, increase, decrease are absent. Synchronous expression, we read all of that. Homogeneous expression of something and expression of non-lineage antigens. Specific examples of these categories of immunophenotypic aberrancies are given in chapter 4. In AML, demonstration of such abnormalities is particularly useful in identifying low levels of residual disease, MRD, at the follow-up. So unfortunately, we don't have cases of MRD to show you all. I was hoping that we would call someone that had some examples of MRD, but that was not material, like that was not done as yet. And I tried to call a few people, but everyone, like few people that I contacted, I couldn't get them to come here. So unfortunately, we won't see any MRD cases. But I mean, MRD cases basically, I mean, even if they would have shown us, they would have shown all the colored cells. And once it is all colored, it is easy to recognize. The real deal for MRD is in the list mode files when it is we have to hunt for those minimal residual cells. So that is most important. And in list mode files, the patient information is hard to like to de-identify them. So that becomes a challenge. Anyways, so MRD is defined as presence of residual AML at level below that detectable of the morphologic evaluation. Several studies have demonstrated that the presence of MRD either post-induction or post-consolidation chemotherapy is a poor prognostic factor. Debate exists as to the sensitivity and specificity of flow cytometry for detecting MRD in AML, the best time point to assess for MRD, and the cutoff of MRD with greatest clinical significance. Let me know if like some of you, or maybe someone, if you do MRD at your place, and if you want to show a couple of cases or maybe more.
Unfortunately, I'm going back at the 29. I'm returning back to work at 29, but you can have another appointment for so that I can show you, but at the end of the week.
Yeah, we'll see. I mean,
Okay.
I'm also starting a new work on 30th.
Yeah,
so
I know.
it might not be.
They started at 30 at the beginning of the month. Because of this, you wanted to end at 29.
Yeah.
I'm returning back Saturday. We'll be back at work 29. So
Yeah.
let me go back and arrange my things, and I will show you cases. But in each case, we can say, let us challenge the group. So you can ask what is the aberrancy in this case.
Right. I was like, your voice got cut. So yeah, I mean, if you have cases,
I'm
go ahead.
telling you, I'm returning back at the 29th to work. I'm returning back
Mhm.
28th, 29. I'll be back to work. Just arrange my papers,
Mhm.
and I will show you cases for MRD, ALL, and AML as well.
Okay.
But just put another appointment, and then I will show you. I'll send it to you, and let us see all together.
Sounds good. Yeah, we'll talk. I'll message you, and we can discuss as to when we can do it.
Okay.
Yeah.
And for each case, you can ask, and you can challenge which in each case we are seeing now. Where's the aberrancy in each case? Like this case,
Right.
where's the aberrancy?
Right. Yeah. CD7 over here too. Yeah. So I agree. I mean, and if you have the list mode files, like if I mean, I don't know what format do you use, but if you have something like Kaluza, people can download Kaluza as well.
No, unfortunately, we don't have Kaluza. I will show you like a picture. It will be more like picture. We have a fixed gate, so I'll show you like pictures, and it will be good, I think. Inshallah.
Okay. Very good. Okay, perfect. Anyone else has, Dr. Gupta, do you have any MRD cases? Is Dr. Gupta
Maybe
here?
I'll dig out. Yeah. I will
Yeah.
have to dig out some
Yeah,
cases.
see if you
I'll
could
see.
dig out some cases, we can learn from them. Because I and Raji, we don't have MRD cases. I right now am in between the jobs I'm doing. I'll be starting the next job on 30th. So I don't have any access to MRD cases. And
Okay, but we
Raji.
can ask in each case where is the aberrancy. Return back to the earlier case and let us ask the people where is the aberrancy, what you see as aberrancy. You are targeting the aberrancy in each case. What is the aberrant marker in the earlier case?
Yeah, that sounds good. That sounds like
Go
a
back
plan.
to the case that you have just read.
Oh, you want to see the aberrance.
Yeah,
So
go
that's
back to the case that you have just
that's what
read.
they were saying,
Yeah,
that there was
in this case, the
aberrancy that
CD33 is negative.
yeah.
Any case, cases of AML, the progenitor AML must have 34117 HLA-DR,
Mm-hmm.
13 and 33. All of these markers have to be expressed in a moderate way. But
Mm-hmm.
in this case, you can see the 45 in the dim, so this is the place of blast. The 34, any marker between 10 to the power 4 to the 10 to the power 5, we consider it as a bright marker. So if you check the 34 in this case, it is a bright marker. We target the intensity of the level of brightness, but specifically we have to use the same marker while searching for the MRD. In this case, the CD33 and the is negative. This is a negative CD33. And the CD38 is extremely dim to negative, and this is also a target. It shouldn't be like this in normal myeloid progenitor. So in this case, we have three markers, three aberrancy: bright CD34, CD33 negative, and CD38 dim to negative. So we have three aberrancy in this case.
Right.
We have to target them while we are asking for the MRD, but putting in mind we have to use the same monoclonal. You shouldn't do another monoclonal. You have to have the same monoclonal that you have used in the diagnostic bone marrow, because each monoclonal have its own intensity. So
Right.
this is the three aberrant marker. We will just dating on the monoclonal cells. We will check for the 34117 and we will check the 1333. So whenever we find 1333 positive, 34 HLA-DR positive, 117, it is progenitor. If we
Right.
will find our residual clone, it should be bright for CD34, negative for CD33, and negative or dim to
Right.
CD38.
Right.
So this is how we target in each case. The diagnostic bone marrow, we'll check the aberrancy, we write it, and we have it in our file. Then whenever there's an MRD case at the end of induction or any time during therapy, we have to target these three aberrant markers. Okay?
Right. Right. So that's what they are showing in this case. Actually, they are showing a case of MRD here, day 28 post-induction. And
Okay.
they are showing this. This is another case. So they are showing that this case had an aberrant CD7 that was expressed in the original one,
Yeah.
and a variable CD15, and there was a variable CD38 as well with a subset positive.
If you can
Then
see
this
here, excuse
blue
me, if you can
population.
see here, the normal myeloid progenitor always have the expression moderate, like this one, 34, 38. If we can, you can check the earlier one. The 34 was very bright. The 38 was extremely dim. This is what expect. But here, the aberrancy is the presence of CD7, which is a lineage infidelity. We have an antigen not related to the same lineage. So this is what we will target on the day 28 and or any other time during therapy.
Right. So that's what they
This one.
have done. Right, exactly. So that's what they have done, this blue population. So basically this red population is the normal marrow regenerating blast, but this blue population that is present, this has the same aberrancy, that CD7. So that's the population of the residual population of the AML at day 28. You're right. So yeah, so let's come to this. Thank you, Dr. Aslan. So
Never
that,
mind.
so that comes to my MRD over here. The upper panel depicts blast gate of a case of AML at diagnosis. The blast aberrantly expressed variably decreased 38 and variable 15 and a strong uniform CD7. The lower panel depicts the blast gate from the marrow at the same patient 28-day post-induction in addition to normal regenerating blasts. So this over here, these are the normal regenerating blasts, and you can see that they are having like no CD7 expression as you can see over here. However, these ones, they are having similar expression. So shown in red, the abnormal blast population representing 0.6%, similar to that seen at the diagnosis in present aqua. The abnormal blast expressed 34, with slightly decreased 38, and uniform CD7. Of interest, as compared to the blast seen at diagnosis, the abnormal blast seen in the specimen post-therapy show less expression of 15, highlighting the immunophenotype may shift post-therapy. Even with such immunophenotypic shifts, the abnormal blasts are easily separated from the normal regenerating blasts. And then over here, they are showing that these blasts, so basically again, the 28-day post-induction, and this was the original immunophenotype as it was basically 34 negative and CD117 was variable. CD33 was uniform positive and CD38 is positive as well. And then in the post-induction, we see that there is this, rather than this uniform homogeneous positivity, now you see that it is more of variable intensities, and this variable intensity is more of regeneration versus the MRD in this case. And in fact, this blast, they were 34 negative, as you see in this population. Over here, they are really 34 positive. So they are really normal marrow blasts that are present in regenerative blasts that are present in this marrow. So the upper panel depicts the AML at diagnosis. Blast express low 45 and bright uniform 33, and heterogeneous 117, low to absent 34, and HLA-DR. The lower panel depicts flow of cytometry of a marrow in the same patient in the day 28 post-induction. The blasts at this time point are mildly increased at 4.6 of the WBCs, but show normal maturational patterns and are present in the context of left shift in the myeloid maturation, indicating a marrow regeneration. So there is also a left shift that they have shown. At this patient, there was a normal cytogenetics and NPM mutation with no FLT3 mutation. The specimen taken at 28 had no evidence of NPM mutation, supporting the flow cytometric impression that those are marrow regenerative blasts. So that's that, a little exposure to MRD and regeneration. MRD detection in AML has traditionally been done by defining leukemia-associated immunophenotype or immunophenotype of abnormal blast that differs significantly from immunophenotype of normal and regenerating myeloblast. The frequency of AML with recognizable leukemia-associated immunophenotype has ranged in various studies from MRD from 60 to 100%, with studies with larger numbers of antigens, more colors in the signature, and studies collecting more than 50,000 events. That's important, yielding greater sensitivity and specificity. Studies utilizing at least 6 colors demonstrate highest sensitivity, and use of at least 6 colors is therefore recommended for MRD evaluation. Although the LAP leukemia-associated immunophenotype strategy is described in most studies, looking only for specific LAP seen at diagnosis is a flawed strategy, and only a subset of blast may show characteristic the LAP at diagnosis, and leukemia blast may undergo immunophenotypic shifts at relapse or post-therapy. Therefore, an approach to MRD testing in AML should look for abnormal myeloid blast, not only the blast with the identical immunophenotype to that described at the diagnosis. The best time point to assess the MRD is somewhat controversial, with some studies suggesting post-induction MRD carries a greater clinical significance than post-consolidation MRD, while other studies suggest opposite. Additional investigation will be required to classify the best time point to evaluate for the MRD. Of interest, some investigations suggest that early blast clearance is of clinical importance, and that MRD at day 16 post-induction chemotherapy has clinical significance. MRD appears to represent continuous variable. However, several groups have opposed several cutoffs for blast percentage at the induction or consolidation, ranging from 0.35 to 1% as clinically significant. Furthermore, one recommends the use of recommends using log decrease in blast from diagnosis rather than blast percentage to determine the MRD. Continued investigation will be required to determine the optimal time for MRD assessment and blast cutoff of greatest clinical significance. At this time in our laboratory, we report MRD as percentage of total white blood cells. Note the time of study with respect to therapy in the body of flow cytometry. Several correlates have been described between immunophenotypes and either genetics or clinical significance. For example, translocation 1517, 821 have genetic changes defining the subtypes of the AML in WHO classification and are associated with improved prognosis as compared to AML with normal cytogenetics, are both associated with characteristic immunophenotypic features. Blast equivalents in AML with 1517 translocation typically have high site scatter without 34 and HLA-DR. We read that and we saw a case of that as well. And blast in 821 show co-expression of 19. We saw a case of that, bright 34, and also some cases of them, they have CD56. Examples of these other immunophenotypic correlates are discussed in the following cases. Several studies have demonstrated correlates between immunophenotypic markers and prognosis. For example, co-expression of 34 HLA-DR has been associated with a poor prognosis and as also expression of 56 in some cases. In patients with normal cytogenetics, several gene mutations, including FLT3, NPM1, SEPA, have been noted to be of clinical significance. Several studies have demonstrated a subgroup of patients with AML most commonly falling into M1 category with cup-like nuclear indentation. So that's NPM1. This subgroup is often negative for HLA-DR and 34. That's that. And has negative cytogenetics and both harbors FLT3 and tandem duplication and NPM mutation, a combination associated with poor prognosis. So NPM alone is a good prognostic thing, but FLT3 along with NPM1 is bad. Additionally, NPM1 mutations, regardless of cytogenetics of FLT3, have been associated with negative CD34. So as we discussed earlier, that NPM1 will be negative for CD34, but HLA-DR would be positive in NPM1 as compared to acute promyelocytic leukemia in which CD34 and HLA-DR both will be negative. So that's something, I mean, that's not a hard and fast rule too though. Okay, so quickly, do we think we need to have summarization of this? Nidhi, can you summarize just the MRD?
Sure, just like very quickly. Okay, so basically minimal residual disease is to look for the low levels of the residual disease, like the abnormal blast, and to distinguish it from regenerating marrow. And as we were discussing, basically it's to look how do we diagnose in practical approach, to look for the blast with aberrancies, with abnormal phenotype. Important point to keep in mind is like to look for abnormal phenotype and don't just go with the blood, the actual aberrancies on present at the time of original diagnosis, because at the time of follow-up there may be new aberrancies, and so like keep in mind that. So any aberrancies at the time following up MRD should be looked up. And MRD they were saying at 16-day post-induction is of clinical significance. And so like we know myeloid markers are MPO, CD13, 33, 15, 38. Aberrancies could be expression of the lymphoid markers, or could be like TDT, which could be seen in 10% cases of myeloid too. Or there is, and then they discuss like those 4 categories, what the aberrancies could be like. And then one thing they discussed was like in MRD, it's log decrease in blast from diagnosis rather than the blast percentage for diagnosis of MRD. I didn't understand that point.
I think that's something that I mean again see the in MRD what I understood was what I understand my understanding is that so first thing that the immunophenotype need not be the same. It can have similar aberrancies, but it can have different aberrancies. And to my understanding, what they are saying that log difference in what it was shown before can happen as well. Like when it was bright, it can become 1 log low, like it can become moderate, or it can become 2 log lows, that it can become negative or dim. So that's what my understanding was of that particular point. And if someone else want to chime, they can.
Can you repeat the question because I couldn't catch?
Sure. The question was, I'm not sure where we read that during the time of MRD, it's log decrease in blast from diagnosis rather than the blast percentage, which is used for the diagnosis of MRD.
Okay. Now, this is according to the scale. You can see scale in the flow cytometry. There is 10 to the power 2, 10 to the 2 to the power 0, 1, 2, 3, and 4. Each one of these are log scale. Each one of these are log scale.
Oh.
Do you know the scatter of the flow?
Yeah, but
It
she's
has a
talking about
logarithmic
the
scale.
difference.
It has a logarithmic scale. The log, you mean it go down. The scale itself goes down. Decrease in the log or change in the log. But actually, we don't choose this. We don't use this. We are depending more on the aberrancy of the markers. And what is added, we didn't say before that this of the immunophenotypic shift that they have mentioned for the CD15. This case is in case of immunophenotypic shift, but we still have an aberrancy, like loss of one of the antigen-related marker 33, or brightness, or CD7 expression. Even with immunophenotypic shift, that means that the patient took therapy, and after the therapy, the monoclonal expression changes. Some of them will appear, or some of them will disappear. And this is what we newly known change from the normal. You have to know the normal. The normal is the expression of 34, 117, HLA-ADR, 13, 33 in a moderate way. Anything, and 38 definitely. Anything changed than this normal is an aberrant. Even if there was something, and when you repeat it again, it changes. And this also another aberrancy, but it's called immunophenotypic shift. The logarithmic scale, as I told you, it is decreased in one logarithmic scale over the scale of the flow cytometry. Then 10 to the power 2 or 10 to the power 3, we can say dim. 10 to the power 3 to the power 4, we say moderate. 10 to the power 4 to 10 to the power 5, we say bright. So if we go from the bright to the moderate, or from the moderate to the dim, this is a log scale difference.
Right. And Nidhi, over here, what they are saying is usually what they are saying that they use the percent cutoff. So they are saying that a clinically significant percentage being 0.035 to 1. But some of the
specific
groups,
percentage, AML is 0.1, and for cases of ALL is 0.1 to 0.01. This
right,
is internationally what is used.
accepted.
But for cases which have you are entering from 500,000 to 1 million, and you have a population more than 50 events. Even if it is low, you have to report it, and report on it and have a comment that this is below the cutoff value. Maybe it has clinical significance at the moment, but it may have a clinical significance later on. And you have to follow very closely, because these cases propagate very early. And this is a Brent Wood also idea. It is one of the research. He said this, that whenever there is even less than the cutoff value of 0.1, but you can see a population more than 50 events, you have to comment that this is below the cutoff value of MRD positive, but it has no significance at the moment, but close follow-up is recommended.
Right.
Can
So
I add
yeah,
one point?
please go ahead.
Yeah, so regarding this log decrease in blast, my understanding is that they are trying to follow the pattern that we do in the quantitative RT-PCR for BCR-ABL, where we look for the log decrease, like 2 log decrease, 3 log, MRD 4.5 or 4. So you see what is the blast percentage at diagnosis, and then you see how much log it has decreased after the therapy. So if
Yeah, that makes
somebody
sense.
had 40% at diagnosis, and now after MRD it is 4, then it is 1 log decrease. If it is 0.4, it is 2 log decrease
Right.
compared to what was there at the diagnosis. So
That
maybe
makes
they are
sense.
talking about that.
Yeah, that makes sense. That makes complete sense. Yes, that's I think that's what they are talking about. You're right.
Yeah, got it. Thank you.
Go ahead, Nidhi.
Yeah, so I think that's it. If I can go and summarize more, but I think that's just like some entities, like
Yeah, that's actually similar to what we have read. Yeah. Okay, this is something that's the same thing that we have been reading. Okay, so did we? So let's read the take-home points. AML is characterized by expansion of blast equivalence, and then flow cytometry assists in identifying immature populations, assigning lineage to the immature populations, and defining such populations as different from the normal blasts. Flow cytometry can aid in blast enumeration in peripheral blood. However, flow cytometric blast in marrow is hampered by hemodilution and variable lysing of mature erythroid elements during specimen processing. Therefore, blast enumeration in the marrow should be performed by morphology. The more immunophenotypically distinct a blast population is from the normal blasts, the easier MRD detection will be. The sensitivity in MRD is maximized with collection of more than 500,000 events and the use of greater than 5 colors. Some subtypes of AML have immunophenotypic correlates. Okay, that's that chapter. Okay, anyone wants to do this flow? They have given up the diagnosis right away, rather than what Raji gives us. This is like right away they have given the diagnosis.
Ash, I can do it.
Yeah, go ahead.
Okay. So again, in the first plot, like as we have been discussing, green population is grans, blue is limbs, and then we have pink monos, and then light sky blue. I don't, is this, I don't know. What
Basophils, I think.
yeah, seems
Low
like
in HLA-DR, and there's some CD38 to them, but not like dim CD38.
okay. Yeah, seems like, and then the onion in the
It could be something else as well, because the side scatter is so low. The basophils will have higher side scatter.
Yeah, I was thinking it could be on NK, like lymphocyte NK lineage, because they both are there together. Basophil should be kind of where the blast and granulocytes, like in that region, below the monocyte, something where they are.
Right.
Okay, and then we have red indicating blast. Then going to the second plot, the blast, they have high CD34, and then they have CD38 positive, and like a small subset is showing like decreased CD38, though they are like most of them are CD38 positive. Then the blasts are negative for CD33, and they are like expressing CD19. So that's a good clue. They are CD13 positive, CD117 positive, homogeneous positivity, and then they are a subset is CD13 positive too. Then they are HLA-DR positive and CD19 positive, most of them actually. Then there's 34 positive and subset is expressing CD56. So basically we have blasts, which are 34 positive, 38 positive, CD13 positive, and then are expressing 19, and HLA-DR positive too, and a subset is expressing 56 too. So basically increased blast, myeloid blast with aberrant expression of CD19 and 56, and then they are losing aberrancies is that they are losing 33 too, and then a subset is bright 13 positive. So these are aberrancies. Like if we'll go with a reading, then expression of CD19 This won't go in diagnostic line, but like aberrance expression of CD19 on myeloid blasts is an aberrancy, and it is indicative of translocation 821. And furthermore, expression of CD56 on these blasts is indicated with poor prognosis.
Perfect. Okay, good. Very good. So that's that. And I mean, you said that 13. You said that 13 is aberrant. I would say that 13 is variable, but I'm not sure if there is like aberrant expression really. But yeah, sure. 33 is aberrant, and as you said, 19 is aberrant, 56 is aberrant. That is bad prognostic indicator. 38 is very bright. That is also some kind of aberrancy over here. Very bright. And you said that some are
ADR
losing
is bright
38,
as well.
which is
Actually, ADR is very bright as well.
HLADR is very bright, and also 34 is very bright too. It's very, very bright. And then you said that some of the cells are losing 38. I think that's like homogeneously bright. Some of the cells are like losing 34. If like I think you might be saying that. Yeah. So all of that. All right.
I still like 13. Isn't it like a spectrum of 13?
Yeah.
Should it
It's
be
a
like
variable
that?
13. Yes, it's a variable 13. I would still, I mean, if you remember your normal myeloid blast, it has like variable 13, right? So I mean, I'm not completely sure. I don't think that there is a 13 aberrancy per se in this one.
Okay.
Yeah. So flow cytometry demonstrates expanded population of 34 positive blasts comprising 18%. So why they are saying 18% here? Can
Because
you?
it's a 21, and it's like even if
Yes.
first you don't
Yeah.
go by the flow, that is the rule number 1. You have to go
Yeah.
by your diff. But still, if you consider it, like still this 18% is significant because there are like those 3 that we know in which percentage doesn't matter. So it is one of
Right.
them.
Right, exactly. The blast express bright 34 and HLA-DR with myeloid markers 117 and 13 heterogeneous, and 34 is low to absent. 33 is low to absent. Blast have CD19 at level just below the background B cells. Express CD56 on the subset. Immunophenotype suggests the possibility of 821, and this translocation was demonstrated by FISH. By morphology, so that's important. Like they had just 16% blast, but that was still AML with 821. Although the blast percentage was lower than 20, the presence of 821 translocation allowed the case to be designated as AML. So that's that. And over here, they are saying there was mild pancytopenia, WBC of 3000, and hematocrit 33, and platelet of 133. And peripheral blood had 10% blast, and the bone marrow had 16% blasts. Okay.
So I have a very basic question in this. So, when I look at the on the fifth one, actually DR versus CD19, if I make an imaginary line through the CD19, to me, it looks like it's negative for CD19. So how you decide that it's positive?
It's a good question. You should not have this much, like whatever we have CD19 over here. So if as we went over in the normal cases, there should be no CD19 in these myeloid blasts. So any CD19 that is expressed in these myeloid blasts is aberrant. Though the CD19 is less than the usual B cells, but still any expression of CD19 in this myeloid blasts will be considered as aberrant.
Got it.
That? Yeah. Okay. So AML may be associated with several translocations that confer favorable prognosis, including, so all these are favorable, 15, 17, 821, and version 16. The later two translocations have core binding factors, involve alpha and beta, respectively. And transcription factors involved in normal myeloid and lymphoid development. The 821 translocation that brings, so AML and CBFA on chromosome 21 and ETO on chromosome 8. And AML with 821 is most commonly associated with AML with maturation, that is M2 type. 821 is more of M2 type by morphology and shows a characteristic immunophenotype profile by flow cytometry. So if you remember, this 821 was the one that had more of salmon colored granules. And this was the one that had a long, slender, single or rod in their blast. So I think they might come to that or might not. Blast in AML typically show expression of markers, so 34 and HLA-DR at high levels. So that's one of the aberrancies, very high 34 and very high HLA-DR. The blast also express myeloid markers, 17, 117 and MBO, with uniform expression in some studies. 13 and 33 are present in most cases, but can be expressed in somewhat lower levels as well. And co-expression of non-lineage markers, 19 and 56, is common in AML with 821. CD19 is reported in 80 to 90% of the patients with AML translocation 821. So it's significant. And when present, the expression of 19 is usually low or variable. That's important. And that's what we are seeing over here, with expression most commonly being lower than that of the B cells. And expression of other B cell markers, including PAX5 and 79A, has also been described, but that will be in either in your cytoplasmic CD79A group, like the cytoplasmic group, or PAX5 by immunohistochemistry. Recognition of this phenomenon is important to avoid misclassification of MPAL. So we know that MPAL, unless you have a strong CD19, or if you don't have a strong CD19, the definition says that you should have more than two markers of either the cytoplasmic CD79A or the other markers. I don't think that PAX5 is in there. I think there are other markers. 20 is there. But again, like that doesn't make it MPAL. And having the CD19 expression that is weak, low, variable, that doesn't make it MPAL. Recognition of this phenomena is important to avoid misclassification as MPAL. The expression of multiple B cell markers is relatively specific for 821. CD56 is also expressed at some level in 70 to 80% of the 821. And 56 expression has been correlated with a poor prognosis. Say again. I think that was a background noise. I'm muting everyone, okay? Okay. So, yeah. So AML harboring KIT mutation and CD56 is a, okay, where we were. Interestingly, in patients with AML harboring the KIT activating mutation, CD56 is characteristically positive, while CD19 expression is decreased to absent. Interesting. So this is a small factoid. Having a KIT mutation will have CD56 positive and 19 decreased or absent. In some cases, abnormal immature myeloid forms represent a majority of the neoplasm, with relatively few CD34 blasts identified, raising the possibility of MDS. Abnormal immature myeloid forms. In such cases, characteristic immunophenotype of the blast will suggest distinction from the myelodysplasia and will alert one to suggest the testing of 821. So take-home points, 821 is most commonly associated with AML with maturation, M2 type, and has a characteristic immunophenotype of by flow cytometry of strong expression of 34 and HLA-DR, expression of 117 MBO, and heterogeneous expression of 13 and 33. And 19 frequently present, co-expressed, and expression of B cell markers 79 PAX5 may be seen. CD56 is frequent and may be associated with the poor prognosis. Okay. All right. This is all more of the theory, and I mean, we can quickly do the summarization. Anidhi, you're available for summarization?
Yeah, sure.
Yeah, go ahead.
Okay. 821 translocation. So basically we had, as we discussed in this case, that the blast would have some aberrancies, which would include, so I'm going to the theory and showing the picture as well. I'm reading from the WHO so that we would have a standard. High intensity expression of CD34, HLA-DR, MPO, and CD13, but a relatively weak expression of CD33. So it's high intensity of 34, HLA-DR, MPO, and 13, but relatively weak expression of CD33. So that's what, before coming to the aberrancy, that's what we saw. High CD34, high HLA-DR, high CD117, and 13-2. That's what they're saying as compared to the Brent. That's what WHO is saying as compared to the Brent Wood, which saying like heterogeneous expression of 13, and then weak expression of 33. That's what we saw here. Then coming to the aberrancies, they can express lymphoid markers like CD19 and PAX5, and may even express cytoplasmic CD79A. Then another aberrancies that we read was CD56 expression, which is of prognostic significance at present and will indicate adverse prognostic significance. Then there are cases with KIT mutation, and in those cases with KIT mutation, those would be CD56 positive and 19 negative and will have adverse prognosis. Another aberrancies that WHO talks about is that population of blasts will show maturation asynchrony. That is co-expression of 34 and 15, because 34 is an immature marker and 15 is a like maturity marker, but the blast would be co-expressing those. So there would be a maturation asynchrony in these cases. So that was about the like aberrancies and the blast immunophenotype. And then for the morphology, 2-3 important points, like Akanksha was saying, salmon colored granules, the long slender or rods. And then for differentiating it from mixed phenotype acute leukemias, I just quickly like refer to the WHO table of MP.
I wanted to ask you if you could just quickly revise that as well. Yeah, please go ahead.
Yeah, sure. So for like, how do you characterize any blast population? For myeloid lineage, we need MPO by flow cytometry, IHC, or cytochemistry. MPO by flow, by IHC. When we do it by IHC, it should be in the cytoplasm, or by cytochemistry, if we can do any. Or for monocytic differentiation, we need 2 of the following markers: non-specific esterase, that's the cytochemistry NSC, 11C, 14, 64, and lysozyme. So that's for myeloid, either myeloid, that is MPO, or monocytic. Then coming to the T-cell lineage, we need bright cytoplasmic CD3, bright cytoplasmic CD3, or surface CD3, which is rare in mixed MPAL cases. Then coming to the B lineage, we need strong CD19 with strong CD19, like not like here, like that some are expressing. It's like strong CD19 is very important, and in uniform strong CD19 with more than one of the following: strongly expressed CD79A, cytoplasmic CD22, and CD10. So strong CD19 with more than one of the following: CD79A, cytoplasmic CD22, or CD10. Or if it is a weak CD19, then more than 2 of the following strongly expressed. If it's a weak CD19, then more than 2 of the following strongly expressed: 79A, cytoplasmic CD22, and CD10. So yeah, that's it.
Good one. So those are cytoplasmic CD79A, CD22, and CD10. So those are the ones that are included in the MPAL definition, and PAX5 is not. So that's something we have to remember too. Okay. All righty. Let's go ahead. Anyone has anything to add or anything to ask?
I have a question.
Amber, go ahead.
We say aberrancy or variability. How can we differentiate? Like this is aberrancy and this is like show variability, like we did in the previous case.
Yeah, see, that's why originally when we had the original first few sessions, we discussed what is normal, and when we deviate from the normal, for example, the variability of 13, variability of 33 is kind of normal. But when you have uniform homogeneous 13 or uniform homogeneous bright 13 less 13, uniform homogeneous bright 33 or dim 33, for example, over here you see the uniform dim 33 that is homogeneous over here. So that those things are aberrant, and there are other aberrant like definitions, and we have been reading that in our prior MDS chapters and the others, that if there is an abnormal marker, for example, an abnormal T or B cell marker that is expressed in a myeloid blast, for example, over here, if there is a CD19, though it is low present, but still it is aberrantly present. That's what we call it, aberrant, that it should not be there in the normal blast, but they are aberrantly present. And then we have other markers like CD7 that we saw in the previous case. That is also aberrant marker, should not be present in the normal myeloid blast. So all of these like we have definitions of aberrancies. There is a paper, very nice paper on MDS aberrancies, and I think they also discussed in the early chapters. Let me quickly show you that. So B cell, NK cell, chronic myeloid stem cell. See here. So they have this nice chapter. This is from the same paper, and I'll go through it so that you understand. Like, this is not the only aberrancies. That's not the only aberrancies that will be present, but these are very well defined aberrancies that they have defined for MDS at least. And as I said, the AML and the other cases, there will be different kind of aberrancies that will be expected, not expected in the normal population. For example, we are talking about the myeloid monocytic population and blast and all those. So they can all have aberrancies. So basically, let me enlarge this. I cannot enlarge more than that. Here. Oh, it's not enlarging. Okay. So if you can see, increase in blast, first thing, expression of immature stem cell, expansion of the immature stem cell compartment. So basically CD34 positive, CD38 negative. Then aberrant expression of the non-lineage markers. That's what I was coming to. So B and T cell markers, or CD56 as well. That's more of NK cell marker. So the aberrant expression of these in the myeloid blasts, they are aberrant, or they are abnormal. And then abnormal intensity of antigen expression. So as I was saying, that 1333 should be more variable. So aberrant 13, which is variable, like which is dim, homogeneous, or dim, bright, for example, that. And then similarly, CD117, CD-HLA-DR, we saw that was pretty bright in that case, which was aberrant. So all of that, and homogeneous expression of those, so 13, 33, 34, 117, and 123, asynchronous expression of the antigens associated with maturity, with antigens denoting immaturity. For example, that Nidhi was saying, bright CD34 with a bright CD15, that should not happen. So if you remember our early on discussions on the Brent Wood article that we were discussing in the initial one, we had the normal maturation patterns that we first saw. So do you remember those discussions? You don't remember? Okay, so let me quickly open that. So there is this Brent Wood article, and oh shit, where is it? So there was this Brent Wood article, and we discussed the B cell maturation, we discussed the T cell maturation, and then I'll go quickly over the myeloid maturation, like what we discussed. So this was the myeloid maturation, and we kind of saw how the granulocytic maturation should be. We didn't see like the normal blast, but we went through the normal case of blast. So when you go back to those sessions and see like what kind of, so for example, as I was saying, that CD13, so you can see that the normal granulocytes, they have variable CD13. Similarly, the normal blast, they have not variable CD13. So all of this kind of maturation pattern that you see in granulocytes, in monocytes, in case of blasts, those should be followed. If they are not followed, that will be aberrant. For example, also they are saying over here, so hypogranularity, decreased CD10, abnormal 16 versus 13, abnormal 16 versus 11B, abnormal 16 versus 14. abnormal retention or absence of CD64, left shift, and increase or decrease by 1/3 log scale in the expression of myelomonocytic antigens and small GPI deficient populations. So these small GPI deficient populations will not make it PNH. That's something that you have to remember, that in MDS, you can have small populations, and also in aplastic anemia, you can have small populations that are similar to PNH, that is GPI deficient. And then the monocytic, left shift, CD56 co-expression, increase or decrease 1/3 log scale of myelomonocytic similarly, and small GPI deficient. And in the erythroid, a decrease. So basically, erythroid should have a bright CD71. If a decreased CD71, that's aberrant. And B cell precursors, decreased hematogones. So, I mean, that's how we determine the aberrant populations. I hope that you must have got a pretty good idea by now.
Yes, thank you
Sure.
so much. I understand. Thank you.
Good. Okay. So we were here. Okay. Alrighty. Anyone wants to discuss about this flow?
I can do that.
Okay.
So here there is like blue population is the lymphs, low on site scatter, high in CD45. Then there is a big red population, which is our population of concern. It's a peripheral blood. It has a high site scatter, moderate 45. It's positive for 117. Predominantly it is on moderate, and some is dim. HLA-DR is negative. And then it is that is something is important. DR is negative. Then it is 13 and 33 is variable here, and 34.
I would say 33 is kind of bright here.
Sorry, yeah. 33 is bright. So 33 bright, that is important, and then 13 is variable, and 34 is negative. So DR negative, 34 negative, and it has a. I would 15. I would call it negative to me. I think.
Yeah, it is negative to low. I mean, very dim to negative because
dim to negative. Yeah.
Yes.
There's no background to compare because it's the only majority.
Yeah, they should have given some background, but
yeah. So, but yeah, dim to negative kind of population there. So
good. So, what do you think? I mean, you already
are negative, 34 negative. I always go for APL. Like you at least have to initiate the trigger, but we read before, we have to always compare with that NPN1 mutation one with it. But whatsoever, you have to like think of APL first and like raise a concern so that they can give ATRA.
Right, exactly. Yeah, very good. So that's that, and this is a typical immunophenotype of a hypergranular APL. The microgranular APL is a little different. So hypergranular APL will be negative for 34, will be negative for HLA-DR, and will be positive for 117. The 33 will be very bright. 13 can be variable, and 15. So if you see the normal promyelocytes, they would be sitting somewhere here. But the 15 would be dim or negative as compared to the normal promyelocytes or even the normal granulocytes and so forth. So that's that. So that's a typical hypergranular APL. And then they have also given an example of this is maturation block. They've also given an example of microgranular APL. You can read that at the same time. So over here, you can see that the 34 is expressed in these. So basically 34 is not entirely negative. There is some expression of 34 in here. And the other aberrant one that they haven't shown, or they have shown? They haven't shown is CD2. So that can be aberrantly expressed as well. So those two are oh, here they have shown. So the CD2 you can see over here. So CD2 is another aberrant marker that will be present in the microgranular variant of APL. So that's something that you have to remember, that the microgranular APL will not be entirely 34 negative. So that's that. All right, good. So over here, they are showing that the DIC like features. So basically, blood tinged sputum, nose bleed, took hours to remit, and that might be because of the low platelet count actually. Platelet of 9,000, and his coagulation studies that he is in DIC. So that's kind of your clinching over there already. And then we have the typical flow. So we already discussed, let's read that. Abnormal cells with low CD45, increased site scatter, the population expresses 117, indicating immaturity without 34 or HLA-DR, and expresses myeloid markers 13, which is heterogeneous, and 33, that's bright. In contrast to normal promyelocytes, this abnormal population expresses low to absent 15. On basis of morphology and flow cytometry, a diagnosis of APL. And then translocation 1517 was positive. So APL, we know that it is M3, subtype of AML characterized by block in maturation at the promyelocyte stage. The subtype is strongly associated with DIC that may be fatal if not treated. Unlike the subtypes of AML, treatment of APL is specific, and then you can give the ATRA therapy, which targets the PML-RARA fusion. Without appropriate therapy, this subtype has dismal prognosis. That's why with appropriate specific therapy, the subtype has better prognosis than AML with a normal karyotype. So APL has a characteristic immunophenotype by flow cytometry that, in conjunction with morphology, allows suspicious cases to be targeted for confirmatory testing. Confirmatory testing would be 1517 or alternative translocation or PML immunofluorescence. Although flow cytometry and morphology are suggestive, the confirmatory testing will be required for the definitive diagnosis. APL, in addition to myeloid blasts, blast equivalents include abnormal promyelocytes that typically predominate in majority of the cases by morphology. Blast equivalents are large cells with moderate amount of cytoplasm containing prominent magenta granules, hypergranular variant. However, in minority cases, the microgranular variant, I'm muting, there is a background coming in. So in microgranular variant, the granules may be recognizable by light microscopy, may not be recognizable. And blast equivalents in APL typically have high site scatter with increased autofluorescence. That's important. And for typical hypergranular variant, the site scatter of the blast equivalents is closer to that seen in the normal myeloid cell, while that of the M3V variant or microgranular, the site scatter is lower and may be low as that seen in the typical myeloid blast. The blast equivalent typically express myeloid markers, including 13 that will be heterogeneous, 33 that will be strong and uniform, CD117 heterogeneous, and MPO, but typically lack the markers associated with the earlier stages of maturation, that will be 34, and HLA-DR. In contrast to the normal promyelocytes, the acquire high levels of that have high levels of 15, the APL blast will have low or absent 15 expression. Other features consistently described in APL includes lower absent expression of integrin subunits 11A and 18, and absence of 133, a myeloid progenitor antigen. M3V shows immunophenotypes similar to hypergranular. However, there are some changes. So we'll have low site scatter, first thing, more likely to be having variable expression of 34 and co-expression of 2. And the expression of 2 has been associated with clinical features, including leukocytosis. So we know that it has a very high WBC count, increased occurrence of thrombotic events, and in some studies, a shorter complete remission duration. Therapy-related APL appears to show similar immunophenotype to de novo APL, as does APL with alternative translocation. The CD56 expression has been described in the subset of APL, and when present, has been associated with the poor prognosis. Okay, so over here they are showing APL versus maturation block. Does anyone want to quickly say what they are saying in this one, or quickly interpret this one?
I can do that. So here they're showing that the red population above is the abnormal population of the cells, which is has a moderate side scatter and a moderate CD45. It has, instead of variable expression of 13, it has a blob-like expression of 13, which is moderate, and is 16 negative. It has a variable 117 expression and is negative for 15. That is how it differentiates, as we were taught before, like from promyelocytes will have 15. It doesn't have 15 here, so that is abnormal over here. Whereas here, when we see our normal grands that we see have a side scatter, like on moderate side scatter and moderate 45, this population has a variable CD13, which is normal, and they have, when they mature, they start expressing, and they are negative for 16. A minute subset might express 16, which are like the very mature one, in which minute subset can have 16. And then in the next plot, they are, when they are mature, they do not have 117 and they express 15.
Okay, cool. Cool. All right. So that's perfect. And sorry, my kid kind of came over here. So that's perfect. Okay. So upper panel shows an example of APL, and that's the typical example of APL with DIM 15 and 16 is negative. They haven't shown the other markers, but that was an example of APL. While lower panel shows a maturation arrest, that is the myeloid forms shown in green. In this example of maturation arrest, the myeloid forms are arrested at the stage of promyelocyte to myelocyte. With only very rare neutrophils. So very rare 13 positive and 16 positive. Then basically the mature forms are very rare in here. They are more of the immature forms, and there is a maturation block in this one rather than APL. And someone might think that there is more of promyelocytes in here, but you can see that these promyelocytes have brighter 15. So that's something that is like differentiating it from the APL as well. So these left-shifted myeloid cells occupy a similar position as abnormal promyelocytes on 45, but in contrast to the abnormal, they have largely lost 117 and acquired high levels of 15. A small normal maturing myeloid population is noted in the example of APL in the upper marrow. Okay, cool. And we read about the microgranular variant already. So then reading to the theory other, more. Other subtypes of APL may have differential diagnosis when considering APL. Maybe in the differential diagnosis. Of all AML, approximately 15 to 20% lack both 34 and HLA-DR. And of these, approximately 50% are APL. And so 50% of those that are lacking 34 and HLA-DR, just the 50% are the APLs, while the remainder are non-APL AMLs. Although APL may be favored on the basis of morphology, increased side scatter or expression of 2 in many cases, other morphologic and immunophenotypic features do not allow the definitive distinction of APL from AML. Therefore, correlation with confirmatory studies is required for the definitive diagnosis. Of note, the absence of 34 and HLA-DR in non-APL is sometimes reported in association with blast morphology, characterized by cup-like nuclear indentation. So they are coming to the NPM1 and FLT3 mutations that have those cup-like blasts. And morphology of the variant microgranular characteristically. So we saw those bilobed in our previous session. So let me mute her. There's some background coming. So bilobe nucleus, we saw that bilobed apple core nuclei, which leads to misclassification of the monocytic leukemia. Similar to the monocytic cells, APL show high levels of CD33 expression and expression of 34 may be seen, and further complicating the classification. However, APL will have bright expression of MPO and absence of HLA-DR, allowing the distinction between the monocytic and the others. Just a second, I'll be back in a minute. Just a second. Okay. Can someone else read this? I'll be back in a minute. Can someone else continue reading this? Nidhi, you want to read quickly?
Yeah, sure.
Yeah.
Okay. There is just one paragraph, then I just read that and then stop.
No, I will be there. Just continue.
Okay. So, okay. I'm reading from here, like when they were differentiating it from FLT3 NPM, which will have like cup-like, those on morphology, they have cup-like nuclear indentations. They are CD34 negative, but HLA-DR positive. Then they are by morphology M3B, which is hypogranular. They have characteristically bilobed nucleus, which may lead to class. So the differentiation here would be monocytic leukemia. Similar to monocytic leukemia, APL shows high level of CD33 expression, and expression of CD64 may also be seen, further complicating the classification. However, APL shows bright expression of MPO and an absence of HLA-DR, allowing distinction of these subtypes. So for the microgranular variant, since they have like bilobed morphology, which we can confuse it with monocytic leukemia, and they can also express 64. How would we differentiate? Based on bright expression of MPO and an absence of HLA-DR. Then immunophenotypes may shift with therapy or at relapse. With standard therapy, incorporating ETRA, blast equivalent will show evidence of maturation that can be identified by morphology and by immunophenotyping. So when we give therapy, the blast can change their immunophenotype as well as morphology. Maturation of abnormal promyelocytes typically manifests with upregulation of more mature antigens, including 11B, 11C, and 158. So that's an important point. Like on giving therapy, as compared to the abnormal promyelocytes, which were blast equivalent, these will have upregulation of the mature markers, including 11B, 11C, and 158. Although these abnormal myeloid precursors show evidence of maturation, the immunophenotype typically differs from that of normal maturing myeloid precursors. For example, CD15 may be expressed at an abnormally decreased level. So even though they are acquiring maturation, but still there would be some differences, like CD15 would be start expressing, but it would be at an abnormally decreased level. Also important to note when following patients with APL post-therapy, APL at relapse has been noted to show similar morphology, but relatively increased expression of 38 and HLA-DR with decreased 13. That's an important point. I didn't know about that. So for following up the post-therapy patients, they'll start expressing 34 and HLA-DR, but there will be decreased 13. So history is important. And then based upon history, you can track the patient, keeping these things in mind. Okay, so the take-home points here are: accurate diagnosis is critical in APML because this subtype of AML can be associated with life-threatening DIC and has a specific therapy, as we know. By flow cytometry, APL has high site scatter, expresses myeloid markers including CD13, bright CD33, that's important, and MPO with CD117 and low to absent CD15. That's important, low to absent CD15, because they are not maturing. The neoplastic cells are negative for CD34 and HLA-DR. Then also the microgranular variant will show co-expression of CD2 and variable expression of 34. So it's like, and keep this microgranular variant in mind, which can have 34 expression. Although morphology and flow cytometry can be highly suggestive, correlation with genetics and or PML immunofluorescence is required for definitive diagnosis.
Perfect. Okay. All right. So that was an easy chapter. We know all of those things, most of those things. All right. Who wants to do this flow?
I can do that.
Okay, go ahead.
Yeah. So our population of interest in here is a green population, which has CD45 moderate and then high on site scatter. It is having expression of CD64, which I would say is towards the brighter end, moderate to bright. 13 is variable expression. It is very bright on HLA-DR, and 14 is negative or down regulated, I would say. So yeah, and then on the next plot, it has some expression, it has expression, moderate expression of 15, and instead of variable 33, it has like a blob like 33 expression. It is negative for 34 and negative for 117. And it has expression of 4 and 56 expression is there. So from this plot, like it has some monocytic markers associated with it, like 56 is an aberrant marker for aberrant marker, which we see in AMLs. 4 is kind of a monocytic marker. It has a bright HLA-DR, which is monocytic. It has down-regulated 14, but it has a 64 expression to it. So yeah, so that's where I am with it. It's like monocytic lineage expression.
So what do you, I mean, you are already very good in flow. What do you think of this down-regulated 14 that you said?
So normally it is like when you see it is immaturity marker, like, you know, 14 is a very good marker that you should target at when you're looking at monocyte. 14, if down-regulated, it is a good hint that monocytes are immature.
Immature, right. And there are these, if you see this purple population over here, which looks like their normal maturing monocytic population as well. So this could be like monoblastic as well, depending on the number of percentages and everything in the marrow. But it could be like a monoblastic leukemia as well.
It has 15 to it. I was between mono, like myelomonocytic versus monoblast, like both of them, because of there is that 15 on it. So that
yeah,
is
but there is no other myeloid marker really.
Yeah, that is true too. Yeah.
117 is negative, 13 is almost negative. There's this 15 and 33, but again, that doesn't make it completely myeloid.
Yeah. But in fact, 33, 33, yeah, it's both. It's like it is little more brighter on monocyte, but I mean, it is fine with the with both. Yeah.
Right. Exactly.
Let's see.
Okay. Let's see. I'm curious now. Yeah. Acute monoblastic monocytic leukemia, M5. Yep. So over here they are showing generalized fatigue, skin rash. Over here they are typically saying swollen gums. So they are coming to the monocytic lineage already. And WBC of 22,000, WBC blast, WBC consisting predominant of mature but atypical appearing monocytes with few, less than 10% immature appearing. So they are saying less than 10% immature appearing monocyte, but this is in the peripheral blood. And bone marrow biopsy and aspiration are performed. And okay, so I'm muting this background coming. Okay, so then they are talking about the plot showing all WBCs. The flow cytometry demonstrates an expanded population of cells with intermediate site scatter and decreased 45. And this population expresses bright HLA-DR monocytic markers that will be 433 and 64 at high levels, but lacking the expression of 14. 34 and 117 are negative, and 13 is heterogeneous. 15 and 56 are uniform in high levels, and findings are consistent with AML with monocytic differentiation, and given the paucity of the myeloid elements, will be described as AML M5. Okay. So acute monoblastic monocytic leukemia is a subtype of AML in which greater than 80% of the cells show evidence of monocytic differentiation. Monocyte, monoblast, and promyelocytes. A minor myeloid component may be seen, which should comprise less than 20%. So that's by definition, it should be less than 20%. It should not be more than 20%, the myeloid component. And blast equivalents in this subtype reach or exceed 20% and may include monoblast and promonocytes with designation of acute monoblastic leukemia. That is the M5A. And the M5A will be monoblast of more than 80%, and M5B will be like when the monoblast are less than 80%. And for like when promonocytes and monocytes are predominating, that will be M5B. Monocytic lineage has traditionally been assigned to on the basis of morphology and cytochemical staining with NSC, and however, flow cytometry in conjunction with morphology allows reliable assignment of lineage in most cases. Monocytic lineage can be defined by variable expression of markers, including 4, 14, 33, 36, and 64. Each of these markers are typically expressed in high levels on mature monocytic cells, and that also express 11C, 13, and HLA-DR at variable levels. However, expression may vary on the immature monocytic cells and may be downregulated on monocytic blasts equivalent in acute monocytic leukemia. Further complicating the evaluation of monocytic neoplasms is the fact that none of these markers is entirely specific for monocytic differentiation. Therefore, understanding of monocytic differentiation is required. So, the most primitive cell recognizable is monocytic differentiation is monoblast. Monoblast express CD4, CD33 bright, CD36 and CD64 bright, and HLA-DR bright. These cells often express, so 34, 33 bright, 64 bright, 36 and HLA-DR bright. And these cells often express 15 at high levels and lack 13. And 14 is uniformly negative on the monoblasts. Promonocytes and monoblasts have similar immunophenotype. However, some studies suggest that antibodies recognizing different epitopes of 14 may assist in differentiating monoblast and promonocytes. An understanding of characteristic of the clone of anti-CD14 used in one's laboratory is critical for evaluating monocytic neoplasms. With maturation to mature monocyte stages, monocytic precursors typically acquire high levels of 14 and increase 13 and show variable expression of HLA-DR and 15. So monocytic precursors will be, the more mature monocytes will be having high levels of 14s. There will be increased 13, variable expression of HLA-DR and variable 15. Abnormal monoblast and monocytes seen in acute monocytic leukemia may show a similar immunophenotype to normal monocytic precursors, rendering these cells difficult to recognize. However, in most cases, the blast equivalents are recognized by aberrantly high or low expression of monocytic marker. Monocytic blast equivalents will be negative for 34, although 117 has been described. The negative cytochemical staining, the MPO, may variably show positive by flow cytometry. So MPO usually negative, but can be positive. Aberrant expression of 56 has been described on the monocytes, monoblast, and acute promonocytes of the AMoL. And expression of 56 should be interpreted with caution in the context of other findings. 56 is described in approximately 50% of the cases, and particularly when expressed in high and uniform level is suggestive of aberrancy. However, expression of 56 has been described in reactive settings as well, and therefore expression of this marker in isolation is not considered aberrant. Of note, patients of AMoL may have more mature component of monocytic cells present in circulation as compared to the marrow. For this reason, in any patients with monocytosis in whom myeloid stem cell disorder is suspected, a marrow study should be warranted to exclude the monocytic differentiation. Okay, this is so this over here on the left hand side they are showing the marrow, and this over here on the right hand side they are showing the peripheral blood. And the point of this being that in the peripheral blood you have more of this mature monocytes that have more that have bright CD14 and HLA-DR, and then there is the immature monocytes that is present in the bone marrow. Rather, like as compared to the mature monocytes, there are a lot more immature monocytes in the bone marrow. So that's the aberrance, like not aberrancy, but that's something that you have to remember, that the peripheral blood will have more of the monocytes, but the actual blast counts will be done by the bone marrow. So flow cytometry of the concurrent peripheral blood show all plots show all white blood cells. In monocytic leukemias, the peripheral blood show more mature monocytic component than the marrow. Flow cytometry from concurrent marrow and peripheral blood from the patient described is shown in the right and left. Immature monocytic cells are shown in aqua, and mature monocytic cells are shown in pink. The peripheral blood shows relatively greater proportion of mature monocytic cells as compared to the immature monocytic cells, with immature in the peripheral blood comprising less than, so immature comprising less than 20% in the peripheral blood. However, the immature monocytic cells are more than 80% of the white blood cells. For this reason, the evaluation of marrow is recommended. So that's That's actually the same case. They are showing the peripheral blood as well as the bone marrow. And in the bone marrow, there were more than 80% immature cells. In the peripheral blood, there were less than 20% of immature cells. As noted, each of the markers described is as expressed in monocytic differentiation may be express high intensities of 33 and 64. Wait, where are we? So as noted, each of the markers described as expressed on monocytic differentiation may be expressed on the cells of other lineage as at varying intensities. For instance, abnormal promyelocytes will also express high levels of 33 and 64. And however, the levels of 64 seen on the abnormal promyelocyte will be typically less than that seen on the monoblast. Additionally, promyelocytes are largely negative for HLA-DR, allowing the distinction in the most cases. CD15 may also be helpful in this regard, as this marker is typically low to negative in the abnormal promyelocytes, but is positive in the acute mono. And if needed, cytochemical, NSE, for monocytic differentiation, and MPO or Sudan black for the myeloid differentiation may be helpful in classifying them. In difficult cases, FISH for 1517 may be considered to definitively exclude the APL. Okay, here, someone wants to take this? So this is just the differentiation between the acute monocytic and the APML that they are saying.
Yeah, I can do that.
Yeah.
So the top one is acute like AML with monocytic differentiation. So that has like a forward, moderate forward scatter and side scatter. Compared to that, I'm comparing both like 45 and side scatter up and below. So in this APL one, it has a slightly more, 45 is dimmer and side scatter is more than the monocytic lineage, and since they are promyelocyte state, so they acquire granules, so they have more side scatter. Now coming to the plot 64 versus DR. So in monocytic, we know they are very bright on HLA-DR and they are bright on 64. That is an important point. And whereas the APL, they can have some expression of 64, but that could be dimmer as we read before, and they are HLA-DR negative. Then 33 versus 15. So this, what I learned now, is 15 can be strong positive. Here it shows moderate positivity for CD15, and 33 is moderate positive over here. Whereas promyelocyte, because they are abnormal promyelocytes, they are negative towards 15, or they're negative for 15 here, and then 33 is kind of moderate positive. So that differentiates from the normal promyelocytes would have some 15, whereas abnormal one will not have 15. And that also differentiates from the monocytes, like abnormal, like monoblast will have 15 and APL will not have it. Then is 117 and 34 is negative in the monocytes, and these are 34 negative, but 117 is positive in promyelocytes.
Perfect. Okay, I don't think that we need to read all of this now. So another cell type that may be difficult to distinguish from monocytic blast equivalents is CD16 positive monocyte. Wow. CD16 positive monocytes are increased in the peripheral blood in a variety of the reactive settings and show decreased expression of the monocytic markers, that is 14, 33, and 64. In contrast to these reactive mature monocytic cells, monoblasts typically lack 16. So monoblast will not have those 16 expression in the monocytes as compared to the reactive CD16 positive monocytes. Of note, the AML with monocytic differentiation is one of the more common types of AML to present with tissue infiltration. So gingival hyperplasia, lymphadenopathy, cutaneous infiltration, all of these will be seen. When evaluating the tissue specimens, samples from patients with history of AML, a myeloid or monocytic sarcoma should also always be considered. Morphologic evaluation of cytospin may provide clues to the presence of myeloid or monocytic sarcoma, and this possibility may be suggested by appearance of 45 versus side scatter plot. And both monocytic differentiation and expression of 56 appear to be somewhat more common in AML with extramedullary manifestation. So monocytic and expression of 56 with extramedullary. So they are showing a case of myeloid sarcoma here. Someone wants to take this? So over here, go ahead. So over here, they are showing this bright HLA-DR population here as well. And this bright HLA-DR population has bright CD4. And this population is negative for 34, as is negative for 7 as well. So this population is more of the monocytic population that has been there in, possibly this is a tissue lymph node or something like that. And this has been there in the as a myeloid sarcoma. And then there is another population that is blue population. This population is bright in 123, is bright in HLA-DR, and is also having CD4 and some partial CD7 as well. So this population must be that of the PDCs that can be seen in the myeloid sarcomas. And then this another thing that should come into your mind with the 123 positivity and 4 positivity in these PDCs is a BPDCN, but they haven't shown a 56 in here, and the other markers 303 and the other markers that could be of BPDCN. So that's that. So monocytic sarcoma, flow cytometry of this lymph node from a patient with history of acute monocytic leukemia shows dominant population of lymphoid cells on CD45 versus side scatter, and expanded population of monocytic cells. The monocytic cells expresses bright HLA-DR 4 and 33, that is not shown, and low 64, that is not shown. Absent to low to absent 14. Of note, the expanded population of the PDCs, yes. It's noted that expresses bright 23, 123 and HLA-DR with low 7. This population is negative for 56. So they have not shown this, or did they show this? Expansion of PDC has been described in association with tissue infiltration of the monocytic leukemias. Also of note, rare CD34 myeloid blasts are present in these lymph nodes and show abnormal uniform expression of 7. So acute monoblastic monocytic leukemia, characterized by expansion of the cells with monocytic differentiation more than 80% and more than 20% blast equivalence. The blast equivalence in the monocytic leukemia consists primarily of monoblasts and promonocytes. The marrow may show a more immature monocytic component than the peripheral blood. Therefore, marrow evaluation should be performed in all cases of suspected AMoL, in which the peripheral blood blast equivalent count is not sufficient for the diagnosis. Okay. Okay, I don't think that, I mean, if we can do it in 2 minutes, then quickly let's do the summary. Nidhi, you still here?
Yes, I'm here.
Okay.
Okay, so I won't go into like the typical details. I noted some like aberrancies and like flow.
Yeah, just the highlights and everything. Yeah.
Okay, so basically, like coming to the monoblastic monocytic maturation. But first we have monoblasts. Those monoblasts are CD4 positive, CD33 and 64, and CD33, 64, HLA-DR, bright positive. Then they express CD15 at high level. So 4 positivity, 33, 64 HLA-DR bright positivity, and 15 at high level. They lack CD13 and they lack CD14. So those are monoblasts. Then promonocytes, they pretty much share the similar immunophenotype with monoblasts. We differentiate them based upon the CD14 clone, as we were reading yesterday, and no one had experience with those clones, AMoL clones. Then another point, they said the monocytic precursors, they can have high CD14 and increased CD4 with variable expression of HLA-DR and CD15. Then they were trying to differentiate the monoblasts from APML. How do we differentiate this? Because APML can also show CD33 positivity and 64 positivity, as we saw in that plot too. However, CD64 is less positive as compared to monocytes. APML cells are HLA-DR negative. They are CD15 negative. And also we can do cytochemistry like non-specific esterase and confirmation by FISH. Then for any monocytic like leukemia differentiation, we also like look for aberrancies like CD56 expression. So CD56 is an aberration, but it should never be used alone because it can also be expressed in the reactive conditions.
Most specific aberrancies, loss of CD14. And if you see that, then start looking for others. Another differential diagnosis is CD16 positive monocytes, which are usually seen in reactive condition. And because they can show decreased expression of 14, 33, and 64. However, monoblasts would never be CD16 positive. So like that's an important clue. I think those were the new points. Rest is pretty much what we have read for like monoblastic and monocytic leukemia before too.
Perfect. Okay, that's what I wanted to go through quickly. Okay. Okay. Anyone to add anything or to ask a question?
Another thing I just read, like that for myeloid, we were discussing myeloid sarcoma, right, or monocytic sarcoma. So I was just going through the definition, like how do we call something myeloid sarcoma? Because many times, like especially with monocytic, they will show tissue infiltration. So they say a myeloid sarcoma is a tumor mass consisting of myeloid blast with or without maturation and occurring at an anatomical site other than bone marrow. Infiltration of any site of the body by myeloid blast in a patient with leukemia is not considered as myeloid sarcoma unless it presents with tumor masses in which the tissue architecture is effaced. So you can only call it like sarcoma along with the leukemia if the tissue architecture is effaced.
Yeah, that's the key word here, the tissue architecture that is effaced.
Then one more point. So like as we read that these monocytic neoplasms can show proliferation of plasmacytoid dendritic cells. And we read that those are 123 positive, CD4 positive. But how do we differentiate it from BPDC and blastic plasmacytoid dendritic cell neoplasm? Because those are CD56 positive, whereas these proliferations associated with monocytic neoplasms would be CD56 negative.
Perfect. Okay. So we can go ahead with, we have 29 to 36. Actually, not the between 33 and 34 we are not going to do because those are BNT ALLs. And so we have 1, 2, 3, 4, 5, 6 chapters remaining, and we have done, I think, 4 or 5 chapters maybe. We have done 1, 2, 3, 4. 1, 2, 3, 4. 4 chapters we have done. So we can take a 5 minutes break and let's resume and try to do a couple more chapters and then try to call it a day. I don't know when we will do the rest of the chapters. If we are not doing it right now, we can resume in the evening, but it might not be possible to. Tomorrow Raji is going to show the unknown cases, so that's going to happen tomorrow. Let's see. I mean, we can quickly go over, maybe without summarizing or something. And so let's take a 5 minutes break, have some water and stuff like that, and let's resume in 5 minutes. Okay?
Sounds good.
Yeah.
Thank you.
Okay, I'm back.
I'm back.
Okay. All right. So, someone wants to take this one. So,
Yeah.
Yeah, go ahead.
So in this CD45 side scatter, there is a red colored blast population is there. The green one is granulocyte. Then there is a large population of eosinophils. And then there are lymphocytes. And then there is something in between monocyte and blast. So there's arrow to that. Okay. So in this, the blast population is positive for CD3 and negative CD33 variable maybe. CD34 is positive and CD15 is variable. 4 and 64 are positive. And then in this 14 versus HLA-DR, they're all HLA-DR, right? And then there is this small population that they are putting with the arrow, that is the immature monocytes. They are showing actually CD14 negativity. And then the 16 versus 64, I think they are trying to show this 16 negative as eosinophils, and the green ones are the granulocytes, which are showing a maturation pattern. And then the 64 ones are and 16 negative are the monocytes.
Right. So, what do you think of this case? Like, it all depends on the counts as well, as to how much count everything is. But overall, what do you think?
Yeah, this has some myeloid differentiation, some monocytic, and then there are increased eosinophils and increased blasts. So, myelomonocytic, probably.
So, acute, chronic.
Acute, with blast percentage, we can tell.
Yeah, exactly. So, it will be based on the blast percentage. All right, good. So, over here, they are saying in the peripheral blood, there were 5% blast-like cells that were noted. And there was absolute monocytosis, normal WBC count. And then over here, they are saying 45 versus site scatter demonstrates expanded population of the myeloid blast, relatively increase in the monocytic cells, and increase in the eosinophils. Myeloid blast expressing 34 and 117 are shown in the red, comprise for 24%. So we know that it is AMML. And myelomonocytic cells are depicted in the lower panels and include neutrophilic precursors beyond the blast stage, so those were greens, and monocytic cells. By flow cytometry, neutrophilic precursors in monocytic cells comprise greater than 20%. So that's another definition of the WBCs. And monocytic cells are shown in pink, mature, and light blue, the mature ones, and are identified by 3044 site scatter in conjunction with high levels of 34, 33, and 64. Mature monocytic cells express high levels of 14, which is decreased on the immature monocytic cells. The immature monocytic cells comprise approximately 10% of the WBCs, bringing the total percentage of blast equivalence, myeloid blast plus immature monocytic cells, to 34% by flow cytometry. An increase in eosinophils was noted, and that was orange color population. So eosinophils have high levels of 45 and side scatter over here, and then they have dim 64 or negative for 64. So lack the expression of 16 and 64, allowing the separation of maturing myeloid cells and monocytic cells respectively. Tandem bone marrow aspirate sphere demonstrated the presence of eobasals. So that's what they are coming to with those eosinophils. And with the myelomonocytic differentiation, that's like the typical example of inversion 16. The findings are diagnostic of acute myelomonocytic leukemia with abnormal FAB and acute myeloid leukemia with inversion 16 for WHO classification. So again, so acute myelomonocytic is M4 by FAB, and evidence of both myeloid and monocytic differentiation in the subtype AML. Blast equivalence comprise greater than 20% of the WBCs, can include myeloid blasts, monocytes, monoblast, and promonocytes. The determination of myeloid and monocytic differentiation and definition of various blast equivalents were traditionally established on the basis of morphology and cytochemical stains. However, in combination of the morphologic review, now flow cytometry is able to accomplish this task in some cases, providing additional cues to the prognosis. The initial step in establishing the diagnosis of AMML is to determine that blast equivalents comprise 20% or more of the WBCs. As noted, blast equivalents in the subtype of AML can include myeloid, monoblast, and promonocytes. Detection of these variable blast equivalents are detailed. Okay, once it is established that the process of AML processes AML, subclassification of AMML, now they are coming to the definition, will be requiring the demonstration of presence of more than 20% of the cells showing myeloid differentiation, and more than 20% of the cells showing monocytic differentiation. So both the myeloids should be more than 20%, and the monocytes or monocytic differentiation cells should be more than 20%. As noted, this is traditionally done using cytochemical stains and using Sudan black B and myeloperoxidase or to establish myeloid differentiation, and NSC to establish the monocytic differentiation. However, with an understanding of myeloid and monocytic maturation patterns, this can be done by flow cytometry now. And as noted in chapter 1, myeloid and monocytic cells share a common progenitor with progression down a myelomonocytic pathway. The increase in expression of 15, 13, 64 is noted. And as these immature and mature, as these immature and mature cells mature and differentiate towards the myeloid lineage, the level of 33 and 64 expression decreases and 13 decreases. So they are now coming to the normal myelomonocytic differentiation and maturation. So then as they differentiate, the 13 and 64 decreases, 13 there is a dip, and then later on the 13 and 16 will be acquired together. With commitment to monocytic lineage, the level of 33 and 64 remains high, and 14 and 13 increase. Monocytic cells typically express higher levels of HLA-DR than myeloid cells, with myeloid cells sometimes increasing the level of HLA-DR expression with activation. Although some studies suggest that AMML, defined by cytochemical staining, frequently shows less than 20% monocytic cells by flow cytometry. In our experience, careful evaluation will be okay. One particular subset of AMML, the AMML EOs, so the EO basos, is important to recognize, and that will be in version 16 that has a more favorable prognosis. And that is inversion or translocation 1616 and CBFB MYH11. And that has increase in eosinophils and expansion of eosinophils with abnormal precursors having large basophilic granules, so eobasos in the marrow. And this increase in eosinophils and abnormal eosinophilic precursors may be recognized by flow cytometry, as illustrated in this case, depicted in 29.1. Of note, the expression of 34 and 107 is reported to be higher in case of AMML EO than in case of standard AMML. However, clinical significance is unclear. With respect to immunophenotype and prognosis in AMML, with the exception of M3V, CD2 is more commonly seen in the AML M4 than other AML subsets. So CD2 can be seen here as well. When present in the absence of inversion 16, CD2 expression in AML has a poor prognosis. Okay, so acute AMML shows evidence of both myeloid monocytic, evidence of myeloid and monocytic maturation were traditionally determined by cytochemical stains, but can be established by flow cytometry. And subtype of AMML with abnormal eosinophils, so eobasos, are in version 16, and that can be demonstrated by flow cytometry. Okay, cool. So, Nidhi, you want to quickly summarize?
Sure. I think other than like the definition and everything, I'll just discuss about the maturation. So for as the myeloid matured, there is increase in CD15, 33, and 64. but there is a stage comes when there is decrease in 33 and 64, and then there's decrease in CD13. And then CD13 and 16 are acquired together, basically the normal myeloid maturation pattern that we see. Whereas the monocytic, as compared to the myeloid, where CD33 and 64 decrease, in the monocytic, 33 and 64 remains high, and then 14 and 13 expression increases. Whereas as compared to the myeloid, 13 expression had decreased. So I think it's important to know this normal maturation pattern, only then we can understand this abnormal maturation. Then, so we know for AMML, more than 20% myeloid blast, more than 20% neutrophils and their precursors, more than 20% monocytes and precursors. Then important in AMML is eobasos, which are basically eosinophils with basophilic granules. And those cases are associated with usually inversion 16, and they have higher expression of 34 and 1117. Another aberrancy that we noted here was expression of CD2. And when CD2 expression is present in absence of inversion 16, it is usually associated with poorer prognosis. That's it, I think.
Okay, perfect. Anyone have any questions or anything to add? Okay, so I guess we can go ahead. Okay. All right. Oh, that's a cute case. Anyone wants to interpret this one? This was a trick case in Raji's one, but this is kind of normal.
I can do that.
Okay, go ahead.
Yeah, so this one, there is a population of cells which is 45 dim and then is has some site scatter moderate. It is bright on 71. So 71 can be expressed in myeloid, but when it is bright, you think of erythroids, this precursors that you have to rule out, like it's not an erythroid leukemia when it is bright. Dim to moderate can be in myeloid too. Then it is negative for 117 and 34. 33 is negative, and am I yeah, in the next plot there is that arrow is showing the cells which are expressing 33 and some CD71, and then there is in the next plot these the bigger population is negative for 45 is like negative for 45 and 7, so those are erythroids for sure. And then this arrow population has some dim 45 and some 7 expression, and has glycophorin A expression and 36 expression. So glycophorin A and 36 expression in the blast is going with the erythroid leukemia with an aberrant 7 expression on it. So yeah, there, that's where I am. And that in the second last plot where it is all 45 negative, those are, I think, that mature reds are there in that probably. But like this big population is erythroid to me.
Yeah.
Advanced acute erythroid.
Right. What do you think of this aberrant? Like we have this population that is strong blob, and that we have established that it is glycophorin A 36 and 71 positive. So we know that this is a erythroid population. What do you think of this 33 expression and 7 expression and some 45 expression?
So 7 is an aberrant marker which can be present, right. And 33 is not a lineage defining, but like usually like myeloids. That's what 33 is. Mm-hmm. Then where else is it going?
Let's see. I believe that that's just the aberrant, as you said, that CD7 is the aberrant marker. I think that's just the aberrant expression of those and like populations, but we will see more. So CD45 versus site scatter demonstrates an expanded population of blue and decreased 45 and intermediate site scatter. This population has increased forward scatter, suggestive of larger size, and lack expression of 34 or 117, and does express 71, 36 and glycophorin with low 7 and low 33, both on the minor subset. So basically it is more of the aberrancies in the same population. All of the other B and T cell myeloid marker antigen are negative, as were 4161. No evidence of patients previously diagnosed. Oh, there was a BALL. We didn't do the history in this. They must have said.
First line.
Yeah, precursor BALL for routine follow-up 1 year. So basically that becomes a therapy related then. So BLL, the combined morphologic, and so it's a therapy related myeloid neoplasm, best classified as pure erythroid leukemia, which happens very rarely. Of note, the patient has a complex karyotype and no evidence of cytogenetic changes seen in her previous BLL. That's a very good case.
Yeah, I have seen 2 of them in my fellowship. And those were both after BLL. It's somehow related to it.
I see. Okay. Yeah. No, I have seen a couple of cases in my fellowship, and I don't remember them being related to BLL. But I don't know if there is a correlation, like a correlation with BLL. That's what maybe they are showing here as well. That's cool. Okay. Someone wants to quickly, read this page. I'll be in the background.
Sure, I can read it.
Yeah, go ahead.
I'll start from the discussion.
Yeah.
AML erythroid differentiation, AML M6, is divided into erythroid leukemia, that is M6A, and pure erythroid leukemia, that is M6B. Flow cytometry plays a role in diagnosis in each of these subtypes in blast identification and characterization. However, correlation with clinical findings and morphology is required to establish the diagnosis and distinguish AML M6 from MDS and other subtypes of AML. Although dysplasia is commonly seen in the erythroid lineage in AML M6, significant dysplasia, that is in greater than 50% of cells, in other lineages, that is neutrophilic or megakaryocytic, warrants classification as AML with multilineage dysplasia. That's important point, that AML M6, definitely we are seeing like increase in erythroid and blast, and dysplasia can be seen in erythroid population. But if we are seeing dysplasia in other lineages, and that too in more than 50% of cells, then it would be classified as AML with multilineage dysplasia. Additionally, the presence of prior chemotherapy, as was seen in the current case, warrants classification as a therapy-related myeloid neoplasm. So that's important too. Definite subclassification of this subtype of AML as it is currently defined requires careful clinical and morphological correlation. However, recent studies suggest that cytogenetics may ultimately identify poor prognostically significant groups, then morphological classification. AML M6A, erythroid leukemia or erythroid myeloid leukemia, is defined as an acute myeloid leukemia. Can we switch to the next page? Thank you. Is defined as an acute myeloid leukemia in which more than 50% of the cells present are of the erythroid lineage, and more than 20% of the non-erythroid cells are myeloid blasts. So M6A, I don't know if this classification still exists, if I remember correctly from there was so M6A, more than.
Your voice is kind of breaking, Nidhi. Is it breaking for others too?
Yeah, I think background noise. There's some.
Yes.
It's breaking, right?
There is a background noise.
Okay, let me mute everyone. Let me mute all. Okay, Nidhi, now you can try.
Okay, so I think it's still there. Yeah, it's still there. Maybe it's from someone.
Let me mute myself. Go ahead then.
Okay, AML M6A, in which more than 50% of the cells present are the erythroid lineage and more than 20% of the non-erythroid cells are myeloid blasts. This is the only subset of AML in which the erythroid elements are removed from the denominator in generating the blast percentage. So that's important here. Like when we are counting the myeloid blasts, we are counting amongst just among the non-erythroid cells as compared to other categories of AML. By flow cytometry, myeloid blasts in AML M6A resembles those seen in other myeloid stem cell neoplasms, including MDS or AML with or without differentiation. When considering a diagnosis of AML M6A, flow cytometry can confirm that an abnormal blast population is present. but correlation with morphology for accurate enumeration of erythroid elements and myeloid blasts is critical for accurate classification and distinction between AML and high-grade MDS. So basically, morphology is really important here to make the correct, to categorize it correctly. AML M6B or pure erythroid leukemia is a less frequently encountered than AML M6A and is diagnosed when immature erythroid cells comprise more than 80% of the marrow cells. So in M6B, immature erythroid cells are comprising more than 80% of the marrow cells. In M6A, it was more than 50% of the cells, and more than 20% of the non-erythroid cells were blasts. Erythroid blasts are typically low to absent for CD45, and they lack expression of MPO or monocytic markers, as would be expected. They are erythroid, so no MPO or no monocytic, and they are also low or absent for CD45. The blast may express 117, but characteristically lacks CD34 and HLA-DR. Markers indicating erythroid differentiation that may be expressed include CD36, CD71, glycophorin A, which is also called 235A, and heme. However, as noted in chapter 1, introduction, these various markers are expressed at different levels throughout erythroid differentiation. For instance, 71, the transferrin receptor is acquired early in the process of differentiation towards the erythroid lineage and is lost with extrusion of the nucleus. Although retention of 71 and aberrant intensity of 71 expression is described in some myeloid stem cell neoplasms too. So now they're discussing, although these are like erythroid markers, 36, 71, glycophorin A and heme, but all these markers, so they're expressed at different levels during different differentiation stage. CD71, which is a transferrin receptor, is acquired early in the process of differentiation, and it's lost later on with extrusion of the nucleus. CD235A, which is glycophorin, it is acquired at a later stage than CD71, and expression of this marker is maintained through maturation. One critical technical point to note is that CD235A staining should be performed post red cell lysis or on phycold cells, as this antigen is expressed at a high level on erythrocytes, and the antigen excess present in the whole blood can lead to a false negative result on the population of interest. I'm not very familiar with what we just read. If someone is, we can discuss this later. Given these normal fluctuations throughout differentiation and maturation, some or all of these, actually we can switch to the next page. Some or all of these markers may be absent at very early stage of maturation. However, at least one of these markers is typically expressed. It is important to note that markers including 36 and 71A are not entirely specific for erythroid differentiation, and particularly in cases negative for 235A, a complete immunophenotypic panel is required to demonstrate absence of evidence of differentiation towards other lineage. So basically 36 and 71 are not specific, and if glycophorin is negative, then like do the complete panel to demonstrate that absence of evidence of differentiation towards other lineages, because these are non-specific markers and could be expressed in other lineages too. Erythroid blasts are typically negative for markers of lymphoid, although aberrant co-expression of markers including CD7 may be seen. Aberrant co-expression of, they are negative for markers of lymphoid, plasmacytic, and megakaryocytic differentiation. So they are negative for lymphoid, plasma, and megakaryocytic, but aberrancies like CD7 expression can be seen. Also critical to exclude from the differential diagnosis are other non-neoplastic conditions as features of megaloblastic anemia or marrow response to erythropoietin may overlap with morphologically and immunophenotypically with AML M6B. So like other like benign condition like megaloblastic anemia and response to erythropoietin should be kept in differential too, as they can morphology mimic this. Then take home points, and then we'll later discuss the CD235 staining. Let's discuss these. AML M6A is defined by presence of more than 50% erythroid cells, with 20% or greater of the non-erythroid forms being abnormal myeloid blasts. Differentiation of AML M6A and a high-grade MDS requires morphological evaluation for accurate enumeration of myeloid blasts and erythroid precursors, because the latter are underrepresented by flow cytometry. So as we have been discussing this before, AML M6B or pure erythroid leukemia is defined by presence of more than 80% immature erythroid precursors. These typically express high CD71A and 235A by flow cytometry. However, the pattern of expression may vary depending on the level of maturation of the blast. CD117 may be expressed as well. Staining with antibodies against erythroid markers after RBC lysis or phycol treatment. Staining with antibodies against erythroid markers after RBC lysis or phycol treatment is critical because these antibodies may otherwise be in conditions of antigen excess due to the presence of numerous mature red blood cells. Okay, so basically we are trying to lyse the numerous mature red blood cells so that we don't confuse. Okay, so let's CD. So if it's a graph is where it's staining pre-RBC lysis, there are like a big block of cells which are CD71A positive, and somewhere like all of them are CD71 positive, and glycophorin is like dim to negative. And then staining post RBC lysis. So then okay, so we there was just one blob, and then here we have less number of cells, and these are CD71 positive and glycophorin A positive too. So okay, let me read what I just tried to interpret. In A, it shows staining with CD235A prior to red cell lysis, while the panel shows staining with 235 post red cell lysis. The abnormal erythroid population is displayed in both dot plots. In the sample stain pre-red cell lysis, the abnormal population appears to be falsely negative to very dim positive for 235A, as the antibody bound to the abundant unlysed mature red cells present in the sample. So that's a very important point. In contrast, in the sample stained after the lysis, the abnormal population is clearly positive for 235A. Okay, so that's a very important point because here, when we were staining before RBC lysis, the antibody went and it attached to the normal, like the mature RBCs, and that's why like it's giving a false negative picture. After RBC lysis, we can clearly see that the erythroid blasts are glycophorin A.
Perfect. Okay. Can you still see the disturbance in my side?
Yeah. Yes.
There's still a difference. And this was present before, or this was not present before?
Not present before.
Okay. Okay, then let's stop here. And we have, let's see.
I have a question to ask.
Yeah, but I cannot hear you very well, so someone else has to answer. Please go ahead. I'll mute myself.
Okay, so one thing is that the lysed RBCs that the plot they showed. So isn't that it is supposed to be the mature red cells are supposed to be negative 471, right? So I just did not understand that plot well. And the other thing that I want to ask is about that 80% cutoff. One thing that I want to correct here is that Dr. Nidhi said that it was probably not the earlier classification. Actually, that M6A is now included in MDS. So it's not a category of AML. So one thing, so 80% cutoff, I wanted to ask that they have given it that in the monocytic also and here also. So when they are saying 80% with 30% pro-erythroblasts, so the 30% of that 80% or the of the 100% marrow cells, that's one thing that I want to say. Morphology question, it's not a flow question.
So I have WHO, I'll read it from there if it answers. Pure erythroid leukemia, and you rightly said that M6A is now under MDS. That's what I was remembering from the previous reading. Pure erythroid leukemia is a neoplastic proliferation of immature cells, undifferentiated or erythroblastic in appearance, committed exclusively to erythroid lineage. More than 80% cells are erythroid, with more than 30% pro-erythroblasts, with no evidence of a significant myeloblastic component. It doesn't say for those more than 30% pro-erythroblasts if that is like just from the erythroid or the all. I can try reading further if I can find the answer.
Oh, it's not given. That's why I'm asking. If somebody has an experience with morphology, that's why I'm asking, because in the monocytic also they're saying more than 80% monoblasts, so 80%. So I was asking that of all WBC monoblast or of the 80% monocytic component, the 80% of that.
I think when you will see a case of it, it will be more clear to you what they are saying. It's just like when you are seeing erythroid cell, they're not all of them are blasts. So you have to, like when you are seeing the cells, 80% of them you have to like count in the erythroids, but they are not all blast. But amongst those 80, at least 30% should be erythroid like erythroblast or pro-erythroblast. That stage, it should be that stage. You know, when you see a normal maturation of erythroid, there is like different stages, orthochromatic, and then it goes on, and those probably. So it is more clear when you have a case in your hand, and then you will get it. And it's really very straightforward cases. It's not that tough. You will see 80% is erythroid population, and amongst them only 30% is like quite immature to be classified amongst the blast to call it an erythroid leukemia. So that is what it is. Did I confuse you more?
Okay, good job. So if you can still hear me, let's stop the session here, and we can continue the session from acute megakaryocytic and TAM, so that we can do together. And MPAL and BPDCM, these 4 chapters are remaining. So I would suggest maybe try to read by yourself. We might just not go through these chapters, unfortunately. And tomorrow onwards, we'll start with the cases, the brutal cases from Raji. I hope you guys can still hear me. Can you still hear me?
We can hear you.
Okay. Okay. All right then, guys. Bye-bye.
Bye.
Thank
Okay.
you.
Thank you.
Bye-bye. Bye-bye.
Thank you.
Bye. Have a great day.
Bye.